Hello and welcome to the Alliance for Home Health Quality and Innovation's webinar on Managing Risk, What's New with Bundled Payments. My name is Teresa Lee and I'm Executive Director of the Alliance. By way of background, the Alliance was founded in 2008 and is dedicated to the mission of leading and sponsoring research and education on the value that home health care has to offer to patients in the entire U.S. healthcare system. Our webinar today will focus on explaining the developments to date with bundled payments and post-acute care, and what providers will need to understand to be prepared to manage risk in these arrangements. We are very fortunate today to have as our guest speakers Sally Rodriguez and Stephen Scott of Avalere Health. Sally Rodriguez provides data analytics and strategic policy support to Avalere's clients in the post-acute and long-term care sectors to help them navigate the healthcare market. Sally uses a variety of Medicare and Medicaid data sources to conduct original analyses that shed light on key issues in post-acute and long-term care. Prior to joining Avalere, Sally worked as an analyst for the Government Accountability Office, and she had fielded and analyzed HEDIS CAHPS surveys for the Center for the Study of Services. Her academic background is in health promotion, disease prevention, and public health. Stephen Scott provides research, analytic, and strategic support to Avalere's clients in the post-acute and long-term healthcare sectors. Stephen's work is primarily focused on the skilled nursing industry, CMS's bundled payment demonstration, and improvements in care transitions. Prior to joining Avalere, Stephen assisted with research at the University of North Carolina's Gillings School of Public Health and Brigham and Women's Faulkner Hospital. He has a degree in economics from the University of North Carolina at Chapel Hill. Just a few housekeeping notes before we get started. First, Sally and Stephen will speak for approximately 40 minutes and will leave the last 15 minutes to answer questions. Please note that this is a webinar and we control the slides on our end, so do not be surprised if you cannot flip ahead. Second, your lines will be on mute. You can submit questions to be answered during our Q&A period through the Fuse webinar software on your computers or other devices. You can send a question to the speaker to be answered in the Q&A period by sending a question to me, Teresa Lee. Finally, we will also be posting the slides on the Alliance's website after this webinar, and we are recording the webinar and will post the playback on the Alliance's website when the recording is available. So, without further ado, I'm going to turn this over to Sally Rodriguez.
Thanks, Teresa. Good afternoon, everyone. Could you advance to the next slide? I wanted to take a moment to tell you a little bit more about Avalere Health. Avalere is a consulting firm based in Washington, D.C., and we are a strategic advisory services firm that works solely in the healthcare space. So we have a variety of different client types, spanning from everything from healthcare providers to life sciences companies, to foundations and to the government. We have about 250 employees, and again, we are singularly focused on the healthcare space. I want to now turn it over to Stephen Scott and let everyone know that Stephen is really one of our key experts on our bundled payment demonstration team that supports and advises clients in making strategic decisions around their participation and performance in the BPCI demonstration program. So Stephen's going to draw upon all of that experience in his presentation today. Next slide.
Thank you, Sally. So today, we really want to review, give an update on bundled payments in general, but really focus in on the BPCI program as an example for how Medicare is testing bundled payments and really what these types of arrangements mean for providers, particularly home health agencies. So with that said, we'll move into at first a general overview of bundled payments as they stand today. Next slide, please. So bundling is really not a fundamentally new concept. As you know, bundling has been used in some form for a long time now with the Medicare MSDRG payment system. And MSDRG is essentially a payment for a mix of services, a single payment for a mix of services at a hospital. So in that sense, we are used to seeing bundling in some form. The major transition that is taking place now in the policy space is exploring the idea of really expanding the scope of bundled payments to include more provider types, a longer time period, covering really a longer time period of care and covering more types of provider claims and provider types. And this is really an expansion of the scope of a bundle, and it requires participating providers to take on a lot more risk and accountability for the utilization over an episode of care. So really what we'll be discussing today are bundle payments that are structured as broader episodes of care, spanning multiple provider types, including acute care and then also potentially post-acute care. Next slide, please. So some general background of the current policy landscape in relation to bundling. We have seen the idea of bundle payments gain significant policy momentum in recent years. The concept of bundling and bundling post-acute care in particular has been in the President's budget since FY14. The concept was included in the President's budget again recently for the FY16 budget. The Backpack Act, introduced last year, is legislation that would introduce mandatory bundling for post-acute care services, would introduce the concept of a provider or a payer coordinator who manages that bundle, and that was reintroduced in the House again this spring. The Hospitals Improvement for Payment Act in November 2014 also introduced a conversation about bundle payments, bringing up the possibility of a voluntary program, a voluntary bundle payment program under Medicare, but again, introducing the concept of a broader bundled payment that combines acute and post-acute care. Next slide, please. So this is really all reflective of the general shift in mentality to really start moving toward value-based or risk-based payments. HHS recently announced in 2015 that they intend to move at least 50% of all payments under an alternative payment model by 2018. And this announcement alone, I think, has really introduced, really put a lot more momentum behind the idea of risk-based payments and really reaffirmed what we've known for a while, which is that the payments really are moving in this direction, and that providers should be prepared to take on more responsibility and more accountability for utilization, not only within their own walls, but also across the care continuum. So whether it's a bundled payment or an ACO, a medical home, any other alternative risk-based payment models, providers, and specifically post-acute care providers, will be faced with a lot of the same incentives, and there will be an impetus to take on a lot of the same strategic actions as far as working with other players within your care continuum. Next slide, please. So what we've seen is that this momentum isn't only taking place within Medicare. State Medicaid programs are also exploring bundle payments. Arkansas, in particular, has introduced a bundle payment program. It's been active since 2011, and that program tests bundled payments for joints, CHF, upper respiratory conditions, perinatal episodes, as well as ADHD treatment. And so that bundle payment in Arkansas went along with their expansion of Medicaid to start to begin to control costs in that space. Maryland is now experimenting with a global payment system under which payments to hospitals would be limited across all payer types, And while that payment isn't strictly a bundle payment, it does introduce very strong incentives to start improving quality and readmissions. So it does introduce a lot of the same momentum and activity within the care continuum for Maryland hospitals and providers that participate with them. And we've also seen a number of commercial payers such as Blue Cross Blue Shield experiment with bundled payments. We'll really be focusing on the BPCI program today because we have much more visibility into the structure of that program, what providers specifically are doing within that program, and BPCI is testing a number of models that really can serve as an example for what we might see with other payer types in the future. Next slide, please. So similarly, we're seeing this activity with self-insured employers. A number of large self-insured employers, such as Boeing, Walmart, and Lowe's, have been using bundled payments for certain procedures. We've seen it most common in cardiac episodes up to this point. And it's really been a means of not only controlling healthcare costs for the employees, but also providing a more coordinated and streamlined service for patients when they receive this care. Next slide, please. So as I mentioned, today we really wanted to focus on the BPCI initiative. We do a lot of work in this space with providers who are participating in the program or applying to participate in the program and are evaluating their opportunities. And it's really a fascinating program because it's a voluntary program that has garnered a lot of participation, and Medicare is testing a number of different bundled payment models under BPCI. So over the years, as we start to see results for this program, Medicare is really hoping that it starts providing answers to the question of how a bundled payment is best structured, what entity, be it a provider or a third-party manager, a payer, what entity is best equipped to manage a bundle, what services and length of time should be covered under a bundle. Medicare is really testing a wide range of options and structures here. So as the program evolves, it will be very interesting to see which structures achieve the most success. So specifically here on this slide, we have laid out the different structures under BPCI, and we really want to focus in on models 2 and 3, both because they are by far the models that contain by far the most participants, but also the 2 models that really incorporate post-acute care. Models 2 and 3 are both a retrospective bundled payment, meaning that providers participating in the program and all other providers providing care to a bundled payment patient are paid as they normally would be under Medicare. So nothing with respect to initial reimbursement for provider changes under these models, but the participating provider is responsible for a target price. So if Medicare sets a target price for the episode depending on the clinical condition, the target price is based on historic payments to the providers for that condition. And they are ultimately, on a retrospective basis, held responsible for meeting that target price. So essentially the way it works is that total episode payments above the target price would be paid to CMS by the participant, but any amount of episode payments that fall below the target price would be paid to the participant by CMS. So essentially if the participant achieves savings under the episode against the target price, they would receive that savings back from CMS. Model 2 covers a 30, 60, or 90-day time period chosen by the participant and covers the initial inpatient hospital stay, plus the 30, 60, or 90 days of post-acute care. So it covers all Medicare Part A and B claims with the exception of hospice over that time period. So under Model 2, the participant is not only responsible for total payments over the initial hospital stay, but also any post-acute care, which, as you would imagine, introduces the incentive of really taking a closer look at where patients are discharged following this initial hospital stay. one of the key levers we're seeing for Model 2 participants to achieve savings is changing that first site of PAC, or really just reevaluating high quality and efficient post-acute care settings. The participants in Model 2 are primarily physician group practices and acute care hospitals. The Model 3 bundle is structured very similarly, the primary difference being that the episode does not include the initial inpatient hospital stay, so the episode begins upon admission to a post-acute care facility. And the participant or the episode initiator is a post-acute care provider, so that includes home health agencies, skilled nursing facilities, inpatient rehabilitation facilities, and long-term care hospitals. So that post-acute care provider initiates the episode and ultimately holds financial responsibility for the episode. Again, the Model 3 episode is also retrospective and covers either a 30, 60, or 90-day time period. Models 1 and 4 are focused primarily on the acute care hospital. Participation, as you can see, is much lower in these models, under 20 participants participating in each of these models. Model 1 only covers the inpatient hospital stay, whereas Model 4 covers the initial inpatient hospital stay in addition to any readmissions that follow. One other important point to note about BPCI is that while many providers or provider organizations are bearing risk directly for their BPCI episodes, many are also participating with third-party conveners who act as sort of risk managers, provide advisory services, and also bear risk on behalf of those participants. So this, again, gets back to the point of the fact that there are a number of participant structures in BPCI, and Medicare will really be keeping an eye on kind of the most successful structures as far as services included in the bundle and which entity manages the risk ultimately. Next slide, please. So to give a brief overview of the history of BPCI and the timelines that are facing participants moving forward, the program opened up for application in 2011. The structure is such that participants apply initially, enter a non-risk-bearing phase in which they receive data from Medicare, begin to evaluate their opportunities for participation, and then they actively must apply into risk-bearing. So the first cohort of participants moved into risk-bearing in October 2013, then again in January of 2014. It was a fairly small cohort of participants initially. But Medicare, CMS reopened the program in the spring of 2014, and we saw many new applicants enter in that new open period. Those new applicants began bearing risk in October of 2014 and continued to enter risk-bearing on a quarterly basis. So we've had new participants enter this past October, January, and then also recently this past April. The last opportunity for participants to enter risk-bearing is July 1st, and those participants will be applying this upcoming Monday, April 13th, to indicate their intent to enter risk-bearing. And at this point, CMS has indicated that they do not intend to reopen the program to new applicants. They had a lot of interest after the recent open period, and our take is that they're really interested in getting the program underway now and starting to really evaluate results over the next 3 years before determining how to proceed with bundled payments, whether they reopen the BPCI program or introduce another type of voluntary program. Next slide, please. So this map shows us the BPCI participants in Model 2. And again, these are primarily hospital and physician participants. As you can see here, participation is pretty closely correlated to the population of each state. We don't necessarily see a lot of what you would call innovation hotspots or hotspots where you see a disproportionate amount of BPCI participants A lot of participation concentrated in California, Florida, Texas, Pennsylvania. A few interesting states, we have seen very heavy participation in Tennessee. In Minnesota, which has been very active in the ACO program, is actually hospitals in Minnesota are not heavily participating in BPCI. So in total, there are over 2,000 episode initiators participating in BPCI Model 2, but that does include the episode initiators who are not currently bearing risk under the program. So we will see in the next few months the total subset of episode initiators that ultimately enter risk-bearing in the program. Next slide, please. We see a similar picture in BPCI Model 3. There are a larger total number of participants with over 4,000. Again, participation generally concentrated in more populous states. As we move through the presentation, you'll see that there's been a pretty big discrepancy in the participants moving into Phase 2. Model 3 participants have not been as aggressive moving into Phase 2, so Phase 2 being the risk-bearing phase of BPCI. So while we do see over 4,000 Model 3 episode initiators, we expect that number to decrease a lot and expect Model 2 participation to potentially eclipse Model 3 by the end of the program. Next slide, please. And so here in this table, we are listing out the episode initiators, or the number of episode initiators who have moved into risk-bearing recently. And so what we're showing here is the number of episode initiators bearing risk in August of 2014 versus now in January 2013. As of January 2013, there were 2 quarters in between in which participants were able to enter risk-bearing. And what we saw was that the total number of participants in risk-bearing did not increase significantly, only by 1 participant, and that is because the number of new entrants were actually almost matched by the number of participants who dropped out of the program. We saw a lot of entry in Model 2, or more entry in Model 2, indicating that the Model 2 is gaining momentum, but actually saw a net attrition in Model 3. So 27 participants dropped out of Model 3 since August, and all 27 of those participants were home health agencies. So as we'll discuss, the post-acute care industry, and home health in particular, has significant opportunity to participate strategically in BPCI, but we're not seeing necessarily as much opportunity for post-acute care providers to bear risk in those Model 3 episodes and achieve savings, as we've seen for the Model 2 participants, due to the structure of the episode, which, again, we'll discuss in greater detail. But the participation as episode initiators bearing risk has not been as aggressive for Model 3s. Next slide, please. So here we see that across phases 1 and 2, risk-bearing and non-risk-bearing, the majority of the BPCI program at this point is post-acute care. Model 3 represents, as we saw, the majority of the BPCI program, but most of these participants are skilled nursing facilities. Home health agencies represent only 4% of participation in the BPCI program at this point. Again, participation as active episode initiators. And that accounts for about 2% of the home health agency industry in total. Next slide, please. So we'd really like to draw the distinction here between participating in the program as a risk-bearing episode initiator versus taking an active role as a partner with other participants in the BPCI program. And this is really the key area for home health agencies to really start considering. So here on this slide, we've listed the top clinical conditions selected by BPCI participants in the risk-bearing phase, both within the Model 2 episode initiators, so the hospitals and physicians, and the Model 3 home health agencies participating in the program. And the reason we do this is to point out the fact that many home health agencies are actually working with Model 2 hospitals under gain sharing agreements becoming active participants within a hospital or a physician network and within that care continuum for Model 2 participants. So it's very important to start keeping an eye on how home health agencies are participating and which conditions the hospitals or physician practices are most commonly participating under BPCI or other risk-bearing programs. And so what we see in general is that the hospitals are participating with the conditions that are included in the hospital readmissions reduction program, so really aligning the need to reduce readmissions under that Medicare program and also the BPCI initiative. So we're seeing that hospitals are selecting commonly both orthopedic conditions. Major joint replacement of the lower extremity is the most commonly selected condition for Model 2 participants, as well as hip and femur procedures, but also some of those medical conditions that are included in the readmissions reduction program, CHF, COPD, as well as pneumonia and respiratory infections. Looking at the Model 3 home health agency participants in particular, those that are in Phase 2 have more commonly selected medical conditions, so we do see a lot of overlap with the common hospital conditions. Again, CHF, pneumonia, COPD. We're also seeing home health agencies select CABG as well as diabetes. Next slide, please. So here we've really laid out the different roles that home health agencies are playing within BPCI episodes. And we've sort of segmented this between the roles that home health agencies are playing within Model 2 episodes, again, those episodes that contain both the acute care stay and post-acute care services, as well as participation in Model 3, the post-acute care only bundle. And within both of these models, home health agencies do have the opportunity to participate as an active risk bearer or as a gain sharer for a gain sharer participating with a risk-bearing entity under the program. So in Model 2 specifically, as I alluded to earlier, a lot of the opportunity for these participants is to start shifting the first side of post-acute care, so using more efficient, less costly post-acute care settings, attempting to reduce readmissions by developing a more close-knit referral network of post-acute care partners, really aligning on care transitions and working actively with their post-acute care partners. So that's really where home health agencies find themselves participating within these models. One thing that we have been seeing within Model 2 episodes is that physicians and hospitals are attempting to divert more patients away from the SNF and into home health agencies, and really front-loading the Medicare home health episode with more visits and more therapy early on in the episode. The idea of being able to treat a more acute patient population and prevent readmissions. So we've seen this activity probably most commonly with orthopedic conditions, but also some medical conditions such as CHF and UTI. We've also seen hospitals incorporate home health and outpatient rehab, both pre and post-surgery, as part of a surgical bundle. So it's another way that they're really starting to incorporate their home health networks. And kind of within this role, home health agencies are most commonly participating in Model 2 in a non-risk-bearing capacity. So they're participating as a gain-sharing downstream provider with Model 2 hospitals. So the opportunity here, as you'd imagine, is really the strategy to gain more volume as hospitals shift patients downstream from higher-cost PAC settings and really enter a preferred network with hospitals, while there is such a, at the point where there is such a strong impetus for these hospitals to establish those networks. Home health agencies do, of course, face the challenge here of taking on a higher acuity patient population. Can also be difficult to, at first, enter that hospital network. There's certainly competition to align with the hospital's post-acute network, but BPCI does present, again, the impetus to do so, and really a good first mover opportunity to become part of those post-acute care networks. Some home health agencies, however, are participating as risk-bearing entities under Model 2, where they are actually owning a Model 2 bundle that is initiated at a hospital. This structure presents significant financial upside as the home health agency actually receives all of the savings from Medicare under the bundle payment program, and really allows the home health agency to take full control as a post-acute care pathway manager, really managing the referral pathways, determining correct site of post-acute care, and monitoring the patient throughout the entire episode. So while this is certainly can be challenging from an operational standpoint, also presenting more downside risk as a risk-bearing entity, it's really a fundamental challenge for a PAC provider that can be a huge strategic opportunity in really moving upstream actively in managing referral partners rather than sort of continuing as a downstream vendor within a hospital bundle or just within the care continuum. Within the Model 3 post-acute care bundle, home health agencies again are bearing risk on their own, but also participating as non-risk-bearing entities. As a risk-bearing entity, a home health agency is simply an episode initiator, where the episode initiates upon admission to home health services and continues for 30, 60, or 90 days. So the home health agency has a clearly defined role as a Model 3 participant under the BPCI program. They bear financial risk for the episode. But what we have seen is that in these home health initiated episodes, there's much less opportunity for savings because a home health initiated episode is sort of by definition a lower cost episode. There's just less savings available to be achieved against the target price in BPCI, with the exception of maybe areas where home health agencies really do see an opportunity to significantly reduce readmissions in the future. So we've really seen that that's the big reason that the home health agency participation as an episode initiator is so low, is that there just aren't as many savings opportunities with that episode structure. Finally, home health agencies are participating as non-risk-bearing gain sharers with other Model 3 episode initiators. So this would most commonly be within a SNF-initiated episode, so a skilled nursing facility participating in Model 3. Many of these participants are working actively with home health agencies, establishing preferred home health agency referral partners, and really with the goal of reducing readmissions and also reducing length of stay in the SNF by discharging to home health sooner. So in this sense, the home health agency in this capacity has less control over the post-acute episode. They're not really owning the bundle, but it is an opportunity to become a preferred partner within a SNF referral network. So there is certainly opportunity there. Next slide, please. So that concludes our portion of the presentation, really reviewing kind of the state of bundle payments. I'll now pass it on back to Sally to discuss some of the requirements and specifically the data analytics that participants under bundle payment arrangements are using right now to succeed under these programs.
Thanks so much, Stephen. So there are obviously a lot of programmatic details and market behaviors that one has to navigate when thinking about bundled payment or other risk-based arrangements. So you might be thinking, where do I start and how do I really know what I should do? Well, I think we would always say that data is really the key to that and the first step. So before we jump into some specifics about that, I just wanted to make the global observation that though today's focus is on the bundled payment demonstration, we're all aware that there are several ongoing payment and delivery reform models in various stages of implementation. And it can be really challenging for healthcare providers to operate within so many different realities. I'm sure I'm not saying anything that's news to you. However, all of the key Medicare payment and delivery reforms have one crucial commonality, and that is really the need for detailed Medicare data that goes beyond the fee-for-service context. So today's healthcare providers really need to be able to step back and visualize their world through an episode lens that is defined by a time frame and can include multiple providers and services. As your company is graduating from fee-for-service to episodic payment models, so should your data resources. Next slide. Actually, could you go to the next slide, please? So why do you need episodic data? There are some very powerful use cases as identified on this slide. Number one, you can identify inefficiencies in episodes in which you are participating, which can meaningfully impact your operational priorities. You can broaden your view to understand competing facility performance in the episode context, allowing for better differentiation. You can also understand internally how your company and others in your market would fare financially in an episode-based payment model, which in turn could provide a more data-driven approach to strategic planning. If you have episodic data for other facilities in your market, you can also study episodes that don't begin in your own facilities to gain an understanding of hospital performance that allows for the creation of partnerships, as Stephen was discussing. You can also use the 30-day episode data to demonstrate your ability to manage the time frame that is measured by the Medicare spending per beneficiary metric that is within the hospital value-based purchasing program. That can be especially useful for markets that have not adopted many of the newer Medicare models, but that are being held accountable for spending within short episodes under that value-based purchasing program. And finally, episodic data can even provide a leg up in conversations and negotiations with other risk holders like ACOs and Medicare Advantage plans. State-level data are somewhat obsolete in those contexts, and there is a need to understand your data across time periods of interest to those risk holders. Next slide, please. So getting access to robust episode-level data should be a key strategic investment that goes hand in hand with the planning and restructuring that occurs on the operations side. Avalere's Medicare Data Solutions, the Bundled Payment Calculator and the Bundled Payment Performance Navigator, assist in these efforts by taking individual Medicare claims and constructing episodes with them. That allows the users to see dozens of metrics at the episode level. In a minute, I'll show you specifically what these solutions can do. Next slide. So one of the key challenges that PAC providers face today is handling and truly utilizing the wealth of data that are becoming more and more available. Data files are often unwieldy and complex, and many organizations do not have the internal bandwidth to process and interpret the constant flow of data. What Avalere's tools do is make sense of those data streams. For example, as shown in this slide, the 19 files per month for participants in the BPCI demonstration, we make sense of those data streams by leveraging years of programming experience to create episodes and feed those data into intuitive, actionable dashboards that inform your business operations in this new healthcare landscape. Next slide. Let's look at a key use case for episodic Medicare data that is very relevant to today's focus on the bundled payment demonstration. If you're participating in the bundled payment demonstration, you do receive data related to your participating facilities, but what you don't get is historical episode information that spans several years that also includes benchmarking data or other episode-level data for other facilities in the market. Even a PAC provider operating within a bundle that is held by a hospital doesn't necessarily know what the hospital's episode performance is, and thus does not have a great understanding of how best to manage the patients coming from those hospitals and to ensure that the overall episode cost remains underneath the target. A participating hospital also may not know how downstream providers perform in an episode context and thus has no visibility into how their discharging behaviors might impact the overall episode cost. So you can see how episodic data really helps with those limitations. I'm going to quickly walk through what's critical for that kind of decision making and how Avalere's Bundled Payment Calculator, or BPC for short, can meet those needs. In short, the BPC provides episode-level metrics and drill downs for every hospital and PAC provider in the country to inform the evaluation and decision-making necessary to craft a robust, data-driven strategy for survival in this value-based world. So, next slide, please. This is a visualization of what the Bundled Payment Calculator looks like, but essentially it organizes episode data in a series of pie charts, since episodes are a combination of those distinct patient movements, care days, and dollars. The BPC provides the pie charts with distributions of discharges, payments, length of stay, and readmissions. So what it really does is give you full access to key episode-level data that allows for a much broader and deeper view of your market. Unlike many existing tools, the Bundled Payment Calculator includes episodic data for all the providers in the market, allowing users to understand performance not just at their facility or their agency, but at the upstream and downstream facilities that really impact the market. When multiple facilities are involved in bundles, there's really an imperative to understand each facility's performance in order to protect your bottom line. So the Bundled Payment Calculator allows you to do that. Next slide. It's a little detail on the data in the tool. So when you go in, you choose the episode parameters that you're interested in. So duration, we have 30, 60, or 90 days. Conditions, the 48 bundle payment conditions, you can look at them individually or as a roll-up, or you can simply look at all patients. And you can see all the key metrics that describe the distribution and details of that patient movement, spending, length of stay, and readmissions within the specified kinds of episodes that you're interested in. Next slide. So I have gone through and created some case studies of what the data actually show and tried to interpret what that might mean. We're running a little short on time, so I think I will go through this fairly quickly, but we will be sending the slides out for your reference, but hopefully I can give you a sense of what this really means in context. So in this example, we've chosen 90-day major joint replacement episodes that originate with a particular home health agency in the Atlanta, Georgia market. The first thing that the BPC does is provide some summary level data related to the episodes you've chosen to look at, and that is what this gray box is. In this case, the home health agency is performing relatively well in terms of overall episode cost and readmission rates when you compare to the market and state benchmarks. Based on these data, the HHA may decide that taking risk for these major joint episodes is a smart move since they are already below benchmarks. Alternatively, they may compare these to their episodic performance for other types of conditions and determine that they perform better in other episodes. They may also choose to focus on episodes where they're not performing as well as a strategic initiative to affect improvement for other key conditions. These data will allow them to make a more informed decision about that. Next slide, please. The summary level data we just viewed is very useful to begin to understand performance, but the BPC does allow you to go further and drill down into the episodic data. So to illustrate this capability, I put together this quick example where we are looking at hospital-initiated episodes. So again, we're looking at 90-day major joint replacement episodes originating at a hospital in the Atlanta, Georgia market. The summary data here is showing us that there were more than 4,600 90-day major joint episodes in that market area, and that this particular hospital has a very high episode readmission rate compared to the market and state benchmarks, despite a longer length of stay in the hospital. Accordingly, the average episode payment for episodes beginning at this hospital is quite high relative to benchmarks. We can also see that the high readmission rates and episode costs could indicate that there are inefficiencies in the way that they utilize post-acute care during these episodes. And so we can drill down to see that. Next slide, please. So as I mentioned, the BPC provides several pie charts that provide further detail about the episodes. Each pie represents 100% of the 90-day major joint replacement episodes, either at the facility level, the market, or the state level. So in this set of pies, we're looking at the distribution of dollars within those episodes. In the case of this example, the average SNF and home health payments as part of episodes beginning at this hospital are higher than the market and state benchmarks. So the home health payments are just slightly above, but the SNF payments are extremely high relatively. We also see that rehospitalization payments, as indicated by the red pie slice, were slightly higher than benchmarks, which could indicate more highly acute patients returning to the hospital. We can look at the other episode metrics to better understand what's happening in these episodes. Next slide. This set of pies show the discharge destinations from the initiating provider. So it's a great way to get a sense of what is this hospital doing with these patients after they leave the hospital. In this example, the Atlanta Medical Center is sending twice as many patients to SNFs compared to the market average, and much fewer patients to home with or without home health. So this discharging behavior is obviously contributing to that high SNF portion of the total episode cost. Overall, this hospital is aggressively utilizing PAC for these major joint patients, but the heavy reliance on SNFs rather than home health has not led to significant efficiency gains, which we saw in that the readmission rate for the episodes is really no better than benchmarks. And in fact, it's really much worse, despite the heavy use of higher intensity care settings like SNFs. Next slide. So another point about the bundled payment calculator is that you can actually click on any of the pie pieces and it will pop out and tell you specifically what facilities are encompassed by that pie slice. So you get to understand even more about what's driving the episode performance at the individual facility level. So we can look at which home health agencies the hospital is discharging the major joint patients to. So you can see in this example, the hospital is discharging patients to 4 separate home health agencies, but when you look at the rehospitalizations that occurred while patients were under the care of home health, only HHA has had any rehospitalizations. So perhaps that particular agency is not necessarily the best partner for that hospital. So this type of data becomes very critical for facilities and agencies to position themselves against their competitors in terms of the way they impact the hospital-initiated episodes of care when they're thinking about those types of models and partnerships and arrangements that Stephen was describing. Beyond the BPCI demonstration, these data also allow you to make that data-driven case related to your impact compared to your competitors on any episodic model, including ACOs or that Medicare spending per beneficiary measure, and even related to MA plans. Next slide, please. This is an example of how the data can underpin a successful partnership with key facilities in your market. In this example, the Home Health Agency A ran the episode level metrics that you can see in the table here for the major joint patients being discharged from Hospital A. This allowed the agency to make a data-driven case to Hospital A to form an innovative partnership for the care of these major joint patients by touting the relatively low readmission rates and their lower than average payments. So the Home Health Agency was able to use these data and build out their value proposition by highlighting their targeted clinical programming and rehab programs, as well as their effective care transitions programs. So the data just really allow you to build out that value proposition, which can lead to, as in this example, the home health agency and the hospital agreeing to work collaboratively to improve and maintain those low readmission rates, and in exchange, the hospital will direct major joint patients to that home health agency, some of which may have previously gone to SNFs. Next slide. So we've discussed the bundle payment calculator and how it can help providers understand whether and how to participate in the bundled payment demonstration. But as I mentioned before, we do offer solutions for those that are actually participating in the formal demonstration program. So if you are participating, we have a solution that's called the Bundled Payment Performance Navigator. I also wanted to make a note here that that Ockley members have access to preferred pricing on all of these solutions, and so again, we would love to discuss them more outside the confines of this webinar if you have interest. But let's look quickly at the bundled payment performance navigator. Next slide. So the BPN, as we call it, because BPPN was not a great acronym, it was developed and launched earlier this year to help our clients navigate the wealth of data they receive as part of the program. So as I mentioned, the 19 files per month. So based on our work in advising and supporting these clients, we realized that they really need to be able to do three key things with that data. They need to be able to see it, obviously, to look at it and see what it says. They need to then be able to evaluate it and evaluate their own performance based on what the data is telling them. And then, of course, they need to be able to report out on these data to key stakeholders or even to other facilities or potential partners in the market. So as part of our BPN program, providers have access to the tool that we've built, but also have built-in advisory services support so that we can work collaboratively to ensure a full understanding of the data and support you in determining what it can do for your business. Next slide. The key feature of the BPN is the dashboarding capability. So this slide is just laying out some detail around the types of visualizations and analytics that we offer within the tool, including an executive summary, volume, spending, readmissions, and utilization. Next slide. We'll go through these very quickly. I just wanted to show you what the interface actually looks like. So on the left side, you can see a gray filter panel that allows you to filter the data on any number of different variables here, and you can save filters that you want to use in the future. This view is actually showing us what we would call the executive summary. So you're looking at the financial performance across quarters. So it allows you to sort of predict and understand how you're doing financially in the program, as opposed to sort of having to guess and wait for the reconciliation to see how you're doing. Next slide. This is a visualization of individual episodes. So what we've tried to do with our BPN tool is allow for many different users within your organization. So whereas potentially the C-suite wants to see that executive summary, others might need to go down to the individual episode level to really understand how to, redesign the care that's provided within these episodes. Next slide. This is a quick view of the readmissions tab. So we provide a lot of data that you can drill down on around what's happening when people are being readmitted. That's obviously a great way to be able to act on the data immediately, to put programs and processes in place to try and get in front of the readmissions. Next slide. So I will wrap up here, and I really just wanted to recap what is probably the key message in this presentation, which is that, bundled payment models are here. They're probably here to stay, whether it be related to a CMS program or actually a legislative action. And what that means is that you are really going to be required to take on new levels of coordination. So you must be able to manage new risks, and that goal requires a new or enhanced focus on collaboration, analytics, and management. So cooperation with the local partners in your markets is a key to success, since a well-managed bundle will require the participation and alignment across all of the providers. We have been seeing this in the form of tighter or narrowed networks, and while it's important to build those partnerships with the key players, we would stress that these need to be really ongoing relationships dedicated to collaboration over time rather than one-off referral arrangements. Secondly, as I started my piece of the presentation by saying, we really can't overstate the importance of having access to the best episode-level data available, whether you're formally participating in the bundled payment demonstration or not. Access to the episode-level data allows you to generate insights about performance within episodes, both for your own facilities and other providers impacting your bundle. All of these analytics really power benchmarking, strategic planning, decision-making, and competitive differentiation. They really empower you to lead the conversation with partners and payers around your value proposition and your effectiveness as a manager of the risk inherent in bundled payments and other value-based payment models. And finally, organizations must provide support to care redesign processes, and that support relies on the first two steps, having a coordinated network of providers, as well as the critical analytic resources that can inform and support the ongoing care and process redesigns that will ultimately drive overall improvement and cost savings. So the business intelligence solutions that I've discussed today were built with provider and client input and Avalere's expertise to underpin and solidify the critical capabilities needed to thrive. We would love the opportunity to demonstrate more about how the BPN or the BPC can answer the critical business questions your organizations are facing. And if you would like to see more, I definitely would encourage you to contact Stephen or I, or you can send an email to info@avalere.com so we can get a conversation started. And at this time, I'd like to hand the reins back over to Teresa for what is unfortunately an abbreviated question and answer portion. But again, we are always around to start any conversation or try to provide any support around the questions you might be having.
Thank you so much, Sally and Stephen. That was really great. And, we've gotten one question that's come in through the Fuse webinar software, and I hope that any of you on the line who have questions will enter questions through the Fuse webinar box as well. But in the meantime, I asked the question that came in, and it had to do with the early numbers that Stephen presented on who is entering, who's in the Model 2 and Model 3 bundled payment arrangements, and who has attrited out, dropped out of those programs. And I think on one of the slides you'd said that 27 of the episode initiators had dropped out of Model 3 and that all of them were home health agencies. So one question was, do you have any information on why those providers dropped out? And second, why is it that Model 2 appears to be so much more popular as compared to Model 3?
Sure. Thanks. So that's a really good question. And I will say up front that we don't have specific intelligence or information on why those participants dropped. But we do have a lot of experience in the program, and based on what we know, we've developed some hypotheses and kind of started to identify the patterns that are occurring. We have seen, as I think I mentioned earlier, that a Model 3 episode initiated by a home health agency just doesn't present a lot of opportunity to achieve savings, really because the episode is by definition low cost. An episode that starts with admission to a home health agency and then continues for 30, 60, or 90 days is a very low cost episode compared to maybe an episode that initiated in a SNF, or even more so an episode that initiates in a hospital and then covers the entire post-acute care period. So a home health agency initiating an episode is presented with a situation in which they really have to squeeze a lot of savings out of an already low cost episode. And what we've seen is that the opportunity is really, for a home health agency in Model 3, is really in reducing readmission. So if a home health agency sees a lot of opportunity to reduce readmissions relative to where they were in the past, they can have opportunity. But we suspect home health agencies just aren't seeing that under the structure of the program and with the way that the targets are set by CMS. To speak more specifically to the relative success of a Model 2 episode, the Model 2 participants have a lot of opportunity to achieve savings in a higher cost episode, but even more specifically by shifting the first site of post-acute care. So a Model 2 episode contains the acute hospital stay plus post-acute care. So sort of built into their benchmarking are episodes that may have initiated at SNFs, IRFs, LTACs, and home health agencies in the past. So they have the opportunity moving forward to shift patients to lower cost PAC settings and use more efficient PAC providers as a very significant lever to achieve savings. So we suspect that that's why we've seen more aggression within Model 2 and just Model 2 participants seeing more opportunity.
Let me just get this straight then, because if you're a Model 3 episode initiator that is a home health provider, but you've developed partnerships with SNFs and IRFs and LTACs, for example, within your network, does the Model 3 episode within BPCI only kick in if it starts with the home health provider as the first post-acute care setting, even if you've got others within your network?
That's correct. If you are a home health episode initiator specifically, your episodes only start with home health services, yes.
I just want to be clear. So let's say I'm a provider that has multiple different lines of businesses. I've got SNF, I've got IRF, I've got LTAC. It's all integrated. What kind of episode initiator am I?
So if if you're a provider with all the service lines, you could initiate episodes with any of the service lines, but Medicare anchors the episodes off of specific provider numbers or facilities that you enter into the program.
Okay.
So when we list out, for example, a home health episode initiator, that is specifically an individual home health agency with a Medicare provider CCN tied to that home health agency. So Medicare is anchoring an episode off of admission to that provider number. However, the post-acute care company that does have an integrated service line could also list skilled nursing episode initiators by indicating the skilled nursing facilities provider number on their application. But the way we've broken it out, when we're saying that 27 home health agencies dropped, we're actually referring to specific home health agency providers. So you're correct in assuming that there may be more Model 3 episode initiators in the program that own home health as well as other post-acute care provider types.
Yeah, they might have been diverse post-acute care providers in terms of their service lines, for example, not just home health, and they've remained in. Okay, we've got a few questions here. So the first one is, how current is the claims data that's used? I think what they mean is in the tools that you presented. And then, is it possible for internal EMR data to be imported for use into the Avalere dashboards that you presented for further analysis? Mm-hmm. And then finally, this is all from the same person. This is why I'm asking so many questions at once. Do you feel that a small agency would be able to gain momentum within the market through use of the tools that you presented?
Okay, sure. So in terms of the tools that we presented, so the BPN, which is the tool that helps you if you are participating in the program, that tool is almost as real time as you can get with Medicare data because you're feeding in those monthly files from CMS. In terms of the bundle payment calculator, where I went through the case studies about the hospital in Atlanta, that is using the most currently available claims data from CMS, and they have about a year lag. So right now we are looking at 2013 data, and we will be receiving the 2014 data later this year. In terms of the EMR question, that's a great question. I think that's something from a product development standpoint that we really want to do. I would say that right now, to the extent that your data are in a similar format as, fee-for-service claims data, then, it's probably fairly, simple for us to be able to feed in data to our platforms, though we have not created that capability formally thus far. In terms of, the success of a small agency, I think that, if you can make a powerful case to a hospital, it may not matter how big your agency is if you are really performing well against the competition. I think sometimes you have difficulties with larger health systems and larger hospitals in that they often own their own home health agency, so it can be hard to compete with that. But, that's not always the case, and potentially you might have more success targeting different types of hospitals or different sizes of hospitals. I think the other thing I would say is that, with the bundled payment program, the episodes are really condition specific, so you could potentially make inroads around certain types of conditions. If you have really strong differentiated, clinical programming around those things, you might be able to get into an arrangement with a hospital for specific conditions. And kind of on a similar note to that, if you have programs related to your care transitions back to the home, and you feel that you provide some value beyond just being the home health agency, i.e., reducing the risk of readmissions because you're doing great care transitions, or even potentially providing some sort of continuing service or checkup. That I think that type of positioning and messaging also would do a lot for you, even if you are a small agency. Stephen, do you have anything to add? No? Okay.
Okay. I don't think that I'm seeing any further questions. So I want to remind those of you who are on the call that if your organization is an Alliance member, then we have negotiated with Avalere that a discount for use of BPN and Vantage, their tools related to bundling and other types of arrangements. So I want to just remind you guys, as I mentioned at the top of the hour, we are going to be posting these slides on the Alliance's website after this call, and we have been recording this webinar so that once the recording is available, that will also get posted on the website. I want to thank our speakers, Sally Rodriguez and Stephen Scott. You guys have done a great job of presenting the issues, and I think that, to me, listening to this presentation today, it's readily apparent these are really complex arrangements, that there are many strategic considerations that people participating in BPCI will need to analyze. The data is significant, and I also just think that a thorough consideration of all of the issues that might lead to risk in these arrangements is really important. So thank you. And with that, we're going to wrap it up. And thank you so much, and we'll look forward to having many of you on future webinars.